So we are recording, and today we're going to talk a little bit about dementia. Now, Ed, did you start the slides at all?
No.
Okay, good. So I only have about 15 slides today because the idea behind this and why we have such a big crowd is that folks probably have questions on this. So I'm a geriatrician. I take care of folks ages 55 and older. Part of that is primary care, and part of that is specialty memory care. So in my practice, we do memory assessments, we do support for folks with dementias and other cognitive disorders. And I think it's important to just talk about what that looks like, some of the advancements and some of the controversies around modern dementia care. And so, again, I only have 15 slides today because I really want to take questions and get some discussion going. So before that, I just want to go through some of the basic ideas of what is dementia. And not to be too basic, I mean, dementia refers to as a broad category, a chronic, generally progressive memory disturbance. And there are dozens of subtypes of dementia. But from the practical perspective, there are four. And these are the four most common, Alzheimer's again being the most common. Alzheimer's dementia is a chronic progressive type of dementia, meaning that once folks develop a type of Alzheimer's dementia, the trend, if you start it here, tends to be steadily downward at some point. Now, people who develop Alzheimer's change at different rates. So folks who develop Alzheimer's dementia at younger ages, particularly in their 50s, tend to progress pretty quickly. It's really difficult to predict in some ways. We'll talk a little bit about how to do that. Now, even though we might label something as an Alzheimer's dementia, there are many other subtypes, and these are often mixed together. A vascular dementia is a little bit different in that it's caused by changes in the brain, predominantly in people who have a history of tobacco use or really high blood pressure. That causes changes to the small blood vessels in the brain. So it's not, we think about strokes being a blockage of a large blood vessel. Vascular dementia happens when smaller blood vessels are affected and certain areas of the brain don't get enough oxygen. This isn't a one-time thing, this is over many years. And the thing about vascular dementia is, whereas Alzheimer's is kind of this progressive slope, vascular dementia looks more like steps. So someone will have a memory change and then may stay stable for a while. And then something happens. Sometimes it kind of can happen overnight, where you might notice that the person with vascular dementia goes from here to here and then stays like that for a while. We'll talk about managing that as well. These last two are a little less common. I want to point out Lewy body dementia because Lewy body dementia is a little bit different. It's often associated with Parkinson's disease. Not to say that everyone who has Parkinson's has Lewy body, but pretty much everyone who has Lewy body has some type of Parkinson or Parkinsonian condition. And this one can be characterized by some abnormal movements, as Parkinson's does itself. Last one is by far among these the least common. It's called frontotemporal dementia because it affects the frontal lobe and the temporal lobe, a lot of which controls impulse control. It's the reason why people aren't standing on the table right now with their pants off or doing lewd and inappropriate things in public. People with frontotemporal dementia lose some of that inhibition. So they may become aggressive, sexually aggressive, etc. Now, it's important as we think about this, what are the warning signs of dementia? And I'm sorry, I know this is a bit of a small TV for those in the room, but it's not just about changes in memory. I get people in my office all the time who tell me, I'm worried because I don't remember things. And in my head, sometimes I think, well, neither do I, but we need to get to the bottom of this. So yeah, memory loss is a characteristic of all dementias, but that does not mean that everyone who forgets something has a dementia.
Right.
But I think about memory features that are more concerning for dementia. I think about forgetting things that are very deeply important, names and faces of those who they might know, getting lost in their own neighborhood or in a place where they know really well, Doing things like forgetting to turn off the stove, forgetting to lock the door, wandering outside and getting really confused. Those are the more common features that make me worrisome, that make me worried that there might be a dementia or some other cognitive process going on. Forgetting an appointment, not always it. Forgetting the name of someone you just met last week, again, not it. Forgetting why you walked into a room, that's a really common thing that I hear, not necessarily a sign of dementia. And one of the factors that I ask people to reassure them when I'm pretty confident that it's not dementia is, does the memory come back to you later? When you walk into a room and you say, oh, why was I here again? When you walk out 2 minutes later, does it hit you? If so, very reassuring. Like I said, difficulty doing familiar tasks. Folks with a variety of dementias may get lost in their own neighborhood. They may find themselves making mistakes on bills. I have a couple of patients who are financial professionals, and one of the first signs that they might have a cognitive process going on was when they started making mistakes on their taxes. Language problems. You might notice difficulty finding words. I know what the word is, and it's just not coming out. If that's happening a lot, something to bring up. On the other side, there's also the nonsensical language, and this tends to be a little more advanced memory changes, where a person with advanced dementia might talk to you and their brain just keeps on moving with words, but they don't make sense. Time and place disorientation. As anyone, I think I heard someone on the Zoom mention that they care for someone with dementia, especially as dementia progresses. The day-night cycle that we all live by, or at least in theory, even though I'm a night owl, starts to fall apart.
Absolutely.
And so getting confused about what time of day it is,
Yeah.
getting dressed to go out at night, getting confused even though they might be at home and not really knowing where they are. Along with that, changes in judgment. Here it says poor or decrease, that can be true. People's ability to rationalize or to make logical decisions tends to change with dementia. These other two, 6 and 7, go along with that. Mood and behavioral changes. I'm sorry, I'm going really fast, but I want to get through this so we can talk. Mood and behavioral changes. This isn't being sad or being upset. These are quick, often hard to understand changes in a person's mood or how they're behaving. Are they increasingly irritable? Are they sad without there being an obvious reason? Visual spatial changes. Vision and space, this kind of difficulty processing information. This is why it can be hard with some folks who have any sort of memory changes to drive, because to drive a car, you need a lot of different inputs. You have to be aware of all the pedals, to be aware of your steering, to be aware of your GPS, pedestrians, signage. Putting all of that together can get really challenging for someone with memory changes. And then finally, withdrawal. Sometimes folks, when they start to have memory changes, start to change the way that they interact with the world. They might back away from going to events like this that they would normally go to. They may be not spending as much time with their friends or networks as they normally do. Now, any of these by themselves or even combined, I don't want people to sit here and panic and be like, I or a loved one have dementia. These can all be warning signs that prompt further attention. So we have ways of testing, and I'll talk about that in a minute. Whoops. There we go. So one of the common things, the Alzheimer's Association, by the way, has a lot of information for anyone who either cares for someone with dementia, has a dementia, or is just interested in learning more. This is comparing some typical age-related changes. Everyone forgets something. The brain is at its cognitive peak in its late teens to early 20s. So anyone who's beyond that has had some level of age-related change. So missing one bill payment or making a bad decision every once in a while, taking that trip to Atlantic City, that does not mean that someone has dementia. Losing things. On my way out of the house this morning, I could not find my wallet to save my life. It drives my partner absolutely up the wall. Does that mean I have dementia? No, because together we had the ability to retrace steps and find it. Even forgetting what day it is, that can happen. When people have a busy week, there are days where I am asking a patient the orientation questions. What's your name? Where are you? And what's the date? And I have to subtly look at my phone to say, oh, okay, it's the 11th. So some changes are normal and others are not. Now, I mentioned all those types of dementia, and they're all their own entity, but I also think it's important to talk about what is a change in memory, but not quite dementia. This is what we call mild cognitive impairment. These are folks who tend to be going about their lives, who have noticed those changes, and who may score a little bit differently on a memory test. It's pretty common. 10 to 20% of people over the age of 65 have some level of cognitive impairment. And the thing about this is when we do memory assessments and I tell someone they have a mild cognitive impairment, the first reaction is always, oh God, I'm going to develop dementia. And that's not necessarily true. Studies vary, but we say thirds. About a third of people with mild cognitive impairment will progress to some form of dementia. A third of people stay the same, which is to say they have some changes in memory, but not that many. And a third will actually get better through working with a behavioral therapist, working on cognitive strengthening exercises. So we'll talk about all of that in just a minute. The next sections, just so you all know, are just about preventing and treating dementias. But I want to stop and see, does anybody have any questions about the basics here? Yes.
Your first slide about people who smoke getting vascular.
Yes.
Can that start early?
Some changes in the brain do start on an earlier level. So yes, technically, if you ever smoked, you are at higher risk of some level of vascular change. Folks who stop smoking, even if it's late in their life, automatically start lowering their risk of vascular dementia within about 1 to 2 years. So we're going to get through how do you prevent dementia. But one of the things I would say there for someone who has ever smoked, making sure that blood pressure is under control, doing best control of cholesterol to prevent those deposits from building in the brain. Those are all things that are going to be very helpful. Does that answer your question?
Because I'm looking back at my father, who was a heavy smoker.
Yeah.
And he stopped reportedly when the Surgeon General's first report came out of his cancer related.
Wow.
Or caught him in the backyard smoking, and I'm eventually caught him smoking, and they haven't reached fire enough. So he was smoking probably his whole life. But now I'm looking back and thinking, is he having issues that I'm calling something else?
No, it's possible. It is possible. I think the other reality of vascular dementia in particular is when I talk about these brain changes, a lot of folks that I see will have those microvascular small blood vessel changes without dementia. So I don't want people to think that if you've ever had a CAT scan of the head or an MRI of the brain and that's noted, everyone's brain after age 50 starts to shrink a little bit, and almost everyone who lives in this country has some level of changes in the small blood vessels. So not a reason to panic, but definitely the folks who have very severe changes. And hard to say what was going on with your dad, but it's possible.
Well, it's possible.
Yeah. But it's an interesting. Yeah. Another question.
Is there any hereditary involvement here? And if so, is it gender related? Say, in my case, my grandmother and mother and sister all died of dementia, Alzheimer's. But on the male line, it does not appear to be as prevalent.
So that's the interesting thing. When we think about the risk factors, and this is specifically to Alzheimer's, hereditary, so genetic involvement, folks who have a first degree relative, parent, sibling, or not usually child, but parent or sibling who've had dementia are at an increased risk. There is not consistent data about whether or not it's gender related or sex related at this point. The challenge with dementia research, as I think we'll talk about, is anytime we talk about risk factors, you are going to find studies that say yes and studies that say no. So to answer your question, the most significant risk factor is increasing age. Genetics is certainly something we think about. When we hear folks who say, I have memory changes, my mother had these as well, then our level of suspicion is a little bit higher. But I also don't want you to sit here, and I'm sorry to single you out and say, well, because I've had these relatives, it does not necessarily mean I can't give you a percent risk. But risk factors here, we've already covered some of them. Smoking, excessive alcohol use, obesity, not so much. Yes, but it's not as consistent. Diabetes, especially uncontrolled diabetes. If we can control diabetes, we can bring that risk almost back to a baseline. Physical activity is a big one, actually. As people know, many Americans, including probably me, are not as active as we should be. So we'll talk about recommendations for that. The last one that I keep talking to my mom about, who cannot hear anything, is hearing loss. Because hearing is how we connect with the world. One of the factors that's very important for dementia and for preventing dementia is doing things like you all are doing now and being in some sort of communal setting, in engaging with others. Doesn't necessarily mean it has to be family or best friends, but keeping your brain active with something you enjoy doing, talking, asking questions. And if we have hearing loss, it can be a lot harder to do that. So prevention strategies. Number one, managing chronic health conditions, getting your blood pressure under control, getting your diabetes under control. These are things where I tell patients this all the time. It is never too late to start. Yes, some things are reversible, but we can always get folks to a place, almost always get folks to a place where we can get these things managed. Quitting smoking, moderating alcohol use. For those assigned male at birth, no more than 2 drinks a day. Over 65, we say no more than 1, but there's some flexibility in that. I say monitoring medication use because certain medicines can increase the risk of developing dementia. Some of the more common ones that folks love to use, benzodiazepines, Xanax, clonazepam, long-term use of those can very slightly, but pretty consistently increase risk of dementia. One of the most common medicines that we see is Benadryl and other medicines that are what we call anticholinergic. The medicines that dry people's mouths up, make them confused, make it hard to pee and poop. So that's Benadryl, Unisom, any of what we call the first generation antihistamines. I'm not talking about Allegra and Claritin and Zyrtec. But keep an eye out for Benadryl use. And if you're using it, tell your doctor. Getting physical activity going. The recommendations are 150 minutes of moderate intensity activity per week. That can be hard for people. If you're really struggling with things like mobility or pain, talk to your doctors and see if, of course, the physical therapy may help. Cognitive training. I get questions all the time from people saying, well, should I start doing puzzles? And the question I always ask back, I had a patient who bought this big book of Sudoku puzzles in once and asked me, I've been doing these, is it going to help me? And my question back to them was, do you enjoy doing it? No, I hate every minute of it. The answer is no, you don't have to start doing puzzles if you hate doing puzzles. Find something that you enjoy doing that makes you think. You know, whether it's, whether it's puzzles, whether it's giving yourself a heart attack and watching the debate last night, do something that makes you think. Hearing problems, get your hearing evaluated. Fortunately, hearing aids these days are cheaper than ever. They're still not cheap enough, but now that they're available over the counter, it can be a lot cheaper. Sleeping. recommendations on sleep change. This is probably my biggest problem here. None of us sleep enough. That's a reality. If you are struggling with this, talk to your doctor. There are a lot of things that we can work on together. The best sleep is, yes, unmedicated sleep, but if we have to, we can do things. And then working to combat social isolation. Easier said than done, but engaging in groups like this, it really does help. Now, question I get all the time, what about these guys? Prevagen, Great Mind, Renew, all of these brain, adaptogens or nootropic medicines, they call them. And I'm going to tell you that none of these medicines have been proven to harm necessarily, but they've done especially big studies. Watch, the makers of Prevagen are going to sue me after I say this. Prevagen has been proven to have exactly no benefit.
Right.
And it ain't cheap. So I tell most of my patients, I've had folks who have been struggling kind of financially to afford this stuff that costs 50 to 100 bucks a month. And I tell people, don't waste your money on that. Really, don't. Now, there are other supplements that people ask me about. NAC is one that's really become popular lately, N-acetylcysteine. There is some evidence that it can help for folks who already have dementia as far as preventing a downslide, but there is not good evidence that it prevents. Another one that I hear a lot is ginkgo biloba. A lot of people take ginkgo. There's no definitive proof that it's going to be helpful. Ginkgo, I always tell people you have to be particularly careful with if you're on other medicines, especially blood thinners and heart medicines, because it can significantly interact with those. So I always ask my patients what supplements they're taking and certainly talk that through. Omega-3s are probably the one that has the best evidence, though it's still not that strong. So omega-3s are a type of fatty acid that are available in pill form. And the best evidence that we have is that the general risk of any type of dementia is a tiny bit lower when you take omega-3s. That specific to Alzheimer's, where most of the funding has gone, that evidence is not as good. Question?
Is there any research on diet, how that could affect Alzheimer's?
Sadly, not as much. This is an area that medicine admittedly has not completely caught up to. There is evidence as far as diet, as far as the diets that put people at risk of hypertension and diabetes, aka highly processed foods, high amounts of sugar, high amounts of processed carbohydrates can increase the risk. But there is not great studies that I am aware of right now. And if there were, I would hope that I would know about them. So loneliness and social isolation has become a big topic in my field recently, especially with the pandemic. This is a really good review article in case anybody likes to read any of this stuff. And it does show that there is a pretty significant increased risk of multiple conditions for folks who are really feeling the impact of loneliness. And I think this is an area of research that I'm particularly interested in, especially as it relates to LGBTQIA folks coming out of the pandemic. You know, fortunately, we're able to sit here with this really good sized crowd today. That wasn't the case for the better part of 3 years. Specific to LGBTQIA older adults, we know that some of the intrinsic risk factors that folks face, some of the increased rates of depression, and even cardiovascular disease may put people more at risk. We know that caregiver support networks for some folks, maybe even some of the folks here in this room, can be different, especially if you're not closely connected to biologic family. We know that because of historic factors that have kept certain folks from certain communities from saving as much money, making as much money, Alzheimer's disease and dementia are very, very expensive to care for. So these are all, and then the fear of discrimination, fear of what that's going to look like if I am old and gay and can have a memory condition. So a little bit on treatment, because treating dementia medically is pretty controversial, actually. And I'm sure anyone who has had a relative or had a friend or someone who they've cared for or known who's had dementia knows what an incredibly complex, frustrating world this is, where we have multiple medicines that are intended to treat dementia. And I'm going to give you the preview and say none of them work very well, including some of the newest ones. I'm going to show you some of the information on that. The research in this field is moving and it's progressing in ways that is amazing, but we're still not there. So there are, for both Alzheimer's and vascular type dementia, 2 oral medicines that we use fairly regularly. Donepezil and memantine are the common medicines. The challenge with these 2 is that donepezil can make people very dizzy. So when I have a patient who has a mild or moderate dementia and is falling all the time, I get really worried about prescribing donepezil because the very modest benefit that that drug may provide often gets outweighed by a fall and all of the sequelae of that. So what are we thinking about when I say a modest benefit? Any medicine that is approved, so donepezil, memantine, and some of the newer ones that I'm going to talk about, has been tested with numbers on a page, meaning when they look and they say this drug prevents the progression of Alzheimer's, they are looking at numbers on a cognitive test. They are not looking at how that person interacts. They are not looking at function and how they're doing in the world. They are looking at numbers on a test. So you're going to see in a moment what that looks like. This is a very complex chart, but I want people to focus on this area here. This is from a paper on the newer drugs that work to treat Alzheimer's dementia. These are injectable medicines that are actually very targeted to some of the proteins that build up in Alzheimer's dementia. The one that's kind of supposedly the latest and greatest is called lecanemab or Leqembi. This is one that you'll often hear about. Leqembi has been tested, and yes, like I said, it slows the progression of dementia. How? If I were to test a person, let's say person A today, and they have mild dementia, and they score a certain number. So let's say they start 100-point scale. Person A and person B both start at an 82. The person who gets lecanemab, when I test them 6 months or a year later, will score a 76 on that test. The person who does not will score a 73. That is a pretty, while it looks significant, that's half a question or a question more right on my cognitive test. It doesn't necessarily mean that they're doing a lot better. The challenge with these new drugs is getting them started on people can be really challenging, especially for folks who have mobility limitations or behavioral challenges with dementia, because you need to get brain MRIs. These drugs target proteins that are in the brain in dementia that we think might be related. We're not entirely sure. So the problem is when you target those proteins, it gets rid of them. And what often happens is blood will fill that space. So these medicines, in 1,000 people who receive lecanemab for 18 months, this new drug, 109 people out of 1,000, which is pretty high in medicine, 11 to 12%, will have some form of swelling in the brain. 83 people out of 100, in addition to that, are going to have some form of bleeding into the brain. I'm not trying to make this a gloom and doom talk, even though Alzheimer's is a very challenging discussion. But lecanemab for most of my patients is just not a good option. Not just because of cost. Trust me. I get asked all the time about doctors being in bed with the drug companies. Trust me, if I were in bed with the drug companies, I would put everyone on lecanemab because it is going to make somebody an incredible amount of money. But we really need to be thoughtful. There are certain patients who might be most appropriate. People who are, on the milder side, people whose families really feel very strongly about trying every option. Because that's a thing. The people who will not do as well with these newer drugs are people who aren't going to tolerate getting MRIs every 3 months. That's a big thing. Has anyone, you don't have to say it, but think about, has anyone here had a brain MRI? It's not the most fun being put into that machine and have that little cage-like thing strapped over your face. So we're making advances, but we are not there yet. And I think, in the next few years, I think you'll see more of these drugs and hopefully better ones coming out. I hope the founders of lecanemab don't throw a bag over my head when I walk out of here. But people need to know that even though this is a huge breakthrough in some ways, because it does work, it's not without consequence. So when we think about dementia, and I've got 2 more slides and then we'll be done and we'll take questions, we're thinking a lot about support resources. We think a lot about how do we help patients, especially our LGBTQI folks, to make sure that wishes are respected. The way to do that is by documenting advanced care planning, which we talked about at a previous session. SAGE, which is Services and Advocacy for LGBT Elders, SAGE, they flip it when they write it out, has really great resources for this, actually, as do your primary care doctors. If your primary care doctor is not talking to you about this, bring it up to them. For folks who have dementia, or for folks who care for someone with dementia, there is this model called the Alzheimer's and Dementia Care Program, ADC. Jefferson has one based out of our office. I believe Penn has one as well in their geriatrics practice. These are programs that really work to help keep people feeling supported, to monitor and manage some of the signs and symptoms of dementia. Behaviors can often get really disturbing or disruptive, and there's a lot that we can do to help folks with that. We often have connections to geriatric psychiatrists who work with folks with dementia. So there's a lot out there. And I will say, for caregiver support, the Alzheimer's Association has a lot of resources. They actually have this 24-hour phone support line. They have the Alz Aging Online Support Group that's very, very active. A lot of the local medical practices here, including ours, once a month, we do every Thursday morning, I believe, we have a support group for folks with Alzheimer's and dementia and their caregivers. So these are just some quotes from folks who have kind of gone through that. And these are all from folks within LGBTQIA communities. I think as medicine focuses more on LGBTQIA folks and on how family networks and kind of how we fit into this, there's going to be a lot less of people saying, I was the first gay people have ever met. But this is a thought too about how do people react when folks who are LGBTQIA+, when folks develop dementia, and they may be a little disinhibited, or they may act a little differently. How do folks respond to that? And this is one of the areas where, as we try to develop new models of care and better models of care, and actually make people feel like, hey, we are filling a room with 25+ people right now, who are all, any one of you could be my patients, let me just say that. Some of you are. This is a powerful group. This needs to be out there, and medicine needs to pay attention to you all. And that's where I leave it and open it for some discussion, as I just check to see if my schedule is behind. Again, apologies for being late, but we got through it, and hopefully that was helpful. Oops. Questions, concerns, complaints? Yes, sorry. I have one.
HIV and cognitive issues.
HIV and cognitive issues. That so yes, historically there has. Some of that is HIV itself and the changes that it causes in the brain. The risks of cognitive issues in HIV are lower in folks who whose viral load is suppressed. in folks who are consistently on the latest highly active antiretroviral therapy. Some of the older medicines that were used actually may have contributed to some cognitive changes in themselves, which is why we've adapted, adjusted, and come up with newer ones. This is not the first time in history someone's aged with HIV. It's the first time when real research is being directed at a large group of individuals aging together with HIV. And so, yes, if you look at it on paper, there is a higher risk of dementia in folks with HIV, whether controlled or not. But I think as we get better understanding of why that is, some of it's inflammation, some of it's the virus itself, some of it is a history of medicines, some of it is people's personal histories and increased risk of smoking. As we parse out what exactly that looks like, I think we're going to have a lot more information in a few years. Okay.
Question about testing, like what are some basic tests?
Yes.
When would be a good time to create a baseline? Is that through primary care or is that referral to your?
So cognitive testing begins with primary care. And it really begins with you all telling your primary care folks that you're concerned about memory. If you all see a doctor, in general, everyone in this room is, well, most people are entitled to an annual Medicare wellness visit. During that wellness visit, you should be screened with a tool called the mini cog. The mini cog is a very easy tool. It asks people to draw a clock. It's an easy tool, meaning it's easy for us to do, not easy to get correct. It's a clock draw and a 3-word recall, meaning we have folks draw a clock with a certain time on it, and we give folks 3 words, give them a few minutes, come back to them later. We score that on a scale of 5. A score of 3 or less prompts your doctor to do more testing. And, you know, sometimes people are just having a bad day and their mind is all over the place and they're not about it. Sometimes they don't pay attention, but that should be the prompt. From there, anyone's primary care doctor can use a standardized screening tool. People have different levels of comfort with that. One of them is called the mini mental status exam. One is called the MOCA, Montreal Cognitive Assessment. These are pretty quick, 20 to 25 minute. You'll often have to schedule a visit just to do one, but they're pretty quick assessments that can actually get us to a pretty good idea of someone's cognitive function. If that turns up abnormal, that's when you end up seeing a specialist like me in our dedicated memory slots. We have a whole battery of tests that we do in our office. That's about a 90-minute visit. We also have this option of sending people out for neuropsychology testing. I can give folks a pretty good idea of a basic cognitive function after that 90 minutes, or even after 60 minutes. I can say this is most consistent with a mild, moderate, severe dementia or not. If we want very nuanced specifics about language, verbal processing, short and long-term recall, we can send folks for a very long series of tests that are done by neuropsychologists. These are PhDs who sit there with them for 4 to 5 hours. Not everyone goes for that because it can be really hard for people to tolerate. But long story short, to answer that question, starts with primary care. Happily involves us. There are actually a bunch of centers in this town. There's us, there's Penn. I always want to be fair to Penn. I believe Temple has one. And then Crozier actually has a memory assessment center as well. Question in the back.
Do you think that you should get a baseline test for that?
You know, the data has not been great on baseline testing. It hasn't. So we do the mini cog with everyone once a year in my practice. So that's our baseline. But if for someone who has a family history, for someone who is worried about it, for someone who brings up to me concerns about memory, I'll often offer them a chance to, hey, at your next visit, let's make it a little longer. We'll do a MOCA and we'll just put that down as a baseline. So I think we're happy to do that. Question.
Is there any connection with like head trauma causing dementia?
Yes, in short, yes. So different types of dementia can have higher increase, the risk of certain types of dementia can be higher for someone who has had multiple concussions. I forget the number, but there's a certain number. It's either 2 or more or 3 or more concussions over the course of their life. The brain can change in itself from head trauma. So some people here have probably heard of CTE, or chronic traumatic encephalopathy. That doesn't neatly fit into one of these categories of like an Alzheimer's dementia, but it's a cognitive change that's often seen in football players, contact football players. That's just related to repeated head trauma. So the answer is yes, there is, and it's hard to make a blanket statement about that. I'm sorry, that's my answer to a lot today. Hard to make a blanket statement about how much that increases risk. Yeah.
When you were talking about hearing before, is that, is tinnitus connected with that, or is that just a whole separate?
Tinnitus is a whole separate thing. It's one of the most, I always say to patients, tinnitus is one of the most annoying things patients face. And it's one of the most annoying things for us too, because there isn't a great treatment for it.
What's the proper name for that? Tinnitus?
It varies. If you ask 5 doctors, you'll get 4 different answers. So that's our talk. I actually have a moment because my resident is starting with a student.
Doug, I have one question on Zoom.
Yeah,
I've been taking care of my father for 8 years. It will be in November with full-blown Alzheimer's. Just this year, he is now sleeping all day and up all night. And I get up at 3 to take care of him. My question is that Alzheimer's, or is that also age-related since he's 95?
it could be both. I will say the thing about dementia in general, and I'm glad you brought this up, George, thank you. Dementia progresses, and as dementia progresses, people's ability to interact goes down. People's ability to have a meaningful conversation, sometimes energy levels go down. The one thing about dementia that I always tell people, and George, not to single you out for this, but is that as dementia progresses, this fact of people becoming less wakeful, more sleepy, eating less, those are hard realities of dementia. Alzheimer's especially is a terminal illness still at this point, and I'm sorry to say that.
He eats plenty, so forget that one. He loves to eat. But you're right. I mean, it's I've been very in contact with the Alzheimer's Association, and they have the 7 stages. My problem with that I ask my primary all the time with is, my father's had this for 10 years, and they give you time frames on these 7 stages. He's passed every one and he's still with us. Exactly. So I guess I'm blessed, or these are just hypothetical state limits, correct?
And that's a great point, George. So what George is referring to is this thing called the FAST stages, FAST. That goes fast 1 to fast 7. Fast 1 has dementia but not really showing signs. Fast 7 is not able to speak, not able to eat, not able to communicate. And there are, general, so those, to answer your question, George, they use population means. And so as you're saying, somebody who is fast 7 might live X months, and then someone might on the other end live X plus 10 months. So they just put it in as a convenient mean. But yeah, we see that all the time where people hang on to these numbers because everybody wants numbers. Prognosis is hard, but it's always a range. So thank you for that question.
From what I'm hearing, Bruce Willis is apparently at that 7th stage where he can't.
Bruce Willis, so I think he has frontotemporal dementia, and fast stages are specific to Alzheimer's, but it looks like he's pretty advanced from what I've seen.
I'm hearing he can't speak.
Yeah, that's what I've heard too.
And also, that's a question.
Yeah.
Can you explain sundowning?
Sundowning, so that's a great question, actually. So dementia, as it progresses, tends to have some people, when they develop dementia, are very calm, very quiet. Some people get more agitated. And it's not that they're angry, it's not that they're jerks, it's that their body is getting sensory input in and the brain doesn't know what to do about it. So that often happens when things get dark. Now, normally people's bodies work on a nice day-night cycle. You wake up, you go through your day, by the end of the day, you're tired. With folks with dementia, like I said earlier, that gets disrupted. So as the end of the day comes, when most people are getting ready to get calm, sometimes folks with dementia don't know how, they have no way of doing that. So their bodies start reacting to that change in light, the change in energy in a way that other people get really disturbed by. That can be physical aggression, that can be shouting, that can be just not calming down. And there are a lot of strategies that we use in geriatrics, some of which are really basic. Keeping lights on during the day, keeping people awake during the day, putting folks in bed at night, turning lights out, TV off at 9 p.m., well, you know, whatever time. We need to try to structure. We try to do things like feed people at consistent times, not do midnight snacks, it's very tempting for folks to kind of give people with dementia what they're looking for in the moment, because one, it's hard, and two, you don't want to feel like you're depriving someone. But sometimes you really have to kind of force that switch with timing. Very low dose of melatonin can be helpful in those situations. Melatonin helps reset the day-night cycle, doesn't work for everyone. We have a variety of medications that we use to help with that, some of which more harmful than others. We have to be careful with the antipsychotic medicine and stuff. I hope that answers the question.
I bring that up because I've watched the reboot of the Frasier show, and one of the episodes, he pretends that he has dementia. It's a whole thing. And at one point he says he apologizes to his guest and he says, "I'm sorry, I think I was sundowning."
Yep.
Nobody laughed, nobody got the joke, and I'm thinking like, I really didn't understand what sundowning is.
Sundowning is just at its most basic, the confusion that you can sometimes see in folks with dementia that comes up toward the end of the
I
day.
think he had an outburst.
Yep.
He's playing the accident.
Exactly. Question.
With all the descriptions that you gave, I've heard the term creeping dementia. And how does that fit into like what we've been talking about?
So creeping dementia is one of those things that's also called like a subclinical dementia, or there's not a distinct entity called creeping dementia. It's a word that people use to describe sometimes a mild impairment or a dementia that comes on very slowly. So it's not necessarily a different thing. It's just to go back to George's point earlier, everyone's cognitive status changes at a different rate. Some don't change at all, and some change very rapidly. That's kind of a way to describe the slower ones.
Doctor, I know you are under a great deal of pressure to get back.
Thank
Any
you.
closing remarks or questions before we end this section?
I think there was one right.
Just a quick one. So in the beginning, when you were going over the symptoms of dementia,
Yes.
I was like, wow, there's a lot of overlap between ADHD and dementia. But like, as I age, how will I know if it's my ADHD is getting more severe or if it's actually?
It's a really poorly studied area. I'm going to be very honest with you. I think about that a lot.
Okay.
I think for someone like you, as for someone like, I mean, not that I think about people who have ADHD who are in some way not neurotypical. It can be a lot harder. I would ask someone to get a cognitive test a little earlier if that's something you're at all worried about, to just get a baseline.
Thanks, Doc.
This is a great study.
One question, if I can, I'll ask,
File is recorded, so we'll be sending that out.
is this audio working okay?
Yeah, we can hear you, John. Michael,
Doc, getting some of the slides as well.
Yeah.
Wow.
Dr. Danielewicz, can you hear us?
No, I think he's going to one of his patients.
I see. Well, I
That's all right.
don't know if I can answer your question, but
Yeah, I was gonna ask him what's something like PCA only in Hawaii, because I have a relative there who may need assistance.
okay.
I can ask PCA for that and then they'll,
Yeah. Yeah, I think they should be able to refer you, and I can also look into something for you as well.
oh, good, yeah, that's,
Yeah, no problem.
Okay, thanks.
All right.
Thank you.
Have a nice day, everyone.
Have a great day.
right.
Yeah,
Thank
too.
you. Bye.